Thank you so much. And everything I know about FMD, I learned from Dr. Olin and many other speakers who are going to be sharing information with you today. It's really my honor to be here with you all. And we're going to be talking about cervical artery FMD. So you heard a lot about what is FMD already. And so just to recap, a normal artery should be a straight, smooth pipe that provides blood flow. That artery has 3 layers in the wall that gives it its strength, which is going to become important when we talk about complications like aneurysm and dissection. And with FMD, you get a thickening of one of these layers that leads to narrowing and then dilation and narrowing again, creating this kind of beaded pattern that we see in multifocal FMD. We can get bulging of the artery, as you heard, for aneurysm, and then tearing within the wall of the artery, which can cause dissection and separation of the wall layers. This beautiful image is actually available on the FMDSA website, and I think Santi Ganesh's lab created it, but there's a lot of great information there on you, and so I just echo what Pam said about using that resource. You heard that the clinical manifestations of FMD really depend on the affected arteries. So if we kind of focus in on the carotid and vertebral arteries, the main things that we hear patients complain about when they come in are headaches, frequently migraines, pulsatile tinnitus, or that whooshing sound. Frequently, if we put a stethoscope on the neck of the patient up by the angle of the jaw, we can actually hear the whooshing, and that's something we call a bruit. And sometimes patients will present with neck pain. We have other complications like stroke symptoms, and those are by and large related to dissection or aneurysm. For the renal arteries, high blood pressure is really what we see people come in with. So we did an analysis from the US registry for FMD a number of years ago, looking at almost 1,000 patients at the time of diagnosis. And what we found was that on those patients that had imaging from the top of the head to the pelvis, the rate of aneurysm and dissection was about 42% altogether. And if we look at the most common locations of aneurysm and dissection, it really mirrors what we see for FMD. We find most of these complications in the carotid arteries and the renal arteries or vertebral arteries. And so I've broken down here for you the rates of those aneurysms and dissections for those patients. And it really is because of this finding that we recommend getting full body imaging for patients with FMD. Now, a really important point is that there are many other conditions that can also cause aneurysm and dissection. And so the only way that we can say that these particular complications are related to FMD is if we can find those multifocal beads or focal stenosis in a different artery bed. And the reason is there is no other condition that causes the string of beads or focal narrowing, although I'll highlight how sometimes finding the multifocal FMD can be a little tricky sometimes. So again, for any patient with FMD, we automatically get head to pelvis imaging, preferably with a CT angiogram. And the reason for that is with MRA, particularly below the neck, for those of you that have had the study, you'll recall you have to lie very, very still and try not to move. And even a little bit of breathing can register as a regularity in the wall of the artery. And that may be mistaken for multifocal FMD. So when we think about how these complications of aneurysm and dissection form, we can consider that those straight, smooth pipes have to withstand blood and flow pressure. And so they need a certain amount of strength in the wall to do that. And for some reason, patients with aneurysms have weakening of that wall that allows the artery to bulge in that location. And some of the most important risk factors for generating this bulging outside of having abnormal makeup of the artery wall is high blood pressure and tobacco use. So we're usually very focused on these risk factors that we can actually modify to control this. Patients with aneurysm may have no symptoms. I would actually say the majority do not present with symptoms, and we find them on imaging. But if patients do have symptoms, it's typically pain. It may be compression of things around the area that generate symptoms. And the reason that it's so important to find these things is because the larger the aneurysm, the higher the risk for rupture. And these days, we've got really great therapies to prevent that complication. And so if we can find an aneurysm, we can either plan out an intervention to treat it so it doesn't become a problem for the patient, or we can create an individual surveillance plan to re-image that aneurysm over time and make sure it's not changing and becoming higher risk. Now, very importantly, we don't have any FMD specific guidelines when it comes to aneurysms. So we look towards the general guidelines for aneurysms in different locations to guide our therapy. Now, the rate of aneurysms in the brain was investigated using data from the US FMD registry. And what it found was that for patients that had had imaging, the rate of cerebral aneurysms was 12.9%. And this is much higher than the general population. In the general population, the rate of cerebral aneurysms for patients around age 50 is about 3%. Now, risk factors that make aneurysms more risky are the location in the brain, again, the size, how fast it's growing, and whether or not the patient has high blood pressure that's not controlled or history of tobacco use. And what we learned from the US registry was that the location of aneurysms that was found in patients with FMD were in higher risk locations in the posterior circulation in the back of the head. And they were also at a size at which we would consider treating them. And so we have the ability to screen, find these, and then intervene on them before they become problematic for the patient. And that's, I would say, very important for management. So when it comes to the management of aneurysms, we have a few different ways that we think about this. First and foremost, we want to reduce any extra stress on the artery wall. So controlling high blood pressure becomes really important. We'll often recommend some activity restrictions, and I'm going to go through at the end of the talk some lifestyle modifications that I share with my patients, actually regardless if they have an aneurysm. And then we can use surveillance imaging, depending on the location. That might be ultrasound, CAT scan, or MRA. What we're looking for is an increase in the size. And each time we do that, we're reassessing the risk versus the benefit for fixing the aneurysm at that time. When it comes to actually fixing the aneurysm, that again depends on the location and patient risk factors like age or other medical problems that might make a particular approach risky or not. Typically, we're talking about repairing the artery from the aneurysm from inside the artery or endovascularly versus surgically. And I have here some examples of ways that aneurysms are fixed today. So you can see here the catheter is putting in these metal coils in the artery, in the aneurysm. What that will do will be to allow any blood flow in there to clot off and basically block the aneurysm so it can't grow anymore. This is a clipping that you can see that can sometimes be done surgically. And then there's some what we call hybrid or mixed approaches where the interventionalist can put a stent across the aneurysm and even feed coils into that aneurysm to block it off completely. So they've become quite advanced today, and we work very closely with neurointerventionalists for the management of patients that need this. Oh, sorry. Let me go back. Okay, now dissection, again, is that tearing of the artery. And it's really important when I'm seeing a patient with dissection that I look at their actual imaging because there's so many different ways dissections can present. We may actually see the tear in the artery with 2 channels of flow. In some cases, we may see a bulging of the artery in the area of dissection. This type is the one that's most often mistaken for multifocal FMD. It almost looks like someone inflated a balloon and let it deflate. The artery has healed itself after dissection, but it didn't go back to normal completely, and it looks kind of irregular. We may see narrowing of the artery, and we may even see a blockage. So again, review of the imaging is very important. When we think about how patients with cervical artery dissection present, there's a variety of presentations. Headache and facial pain is very common. Neck pain is often common, which is just really in the area of dissection. Nerve injury, or also called Horner's syndrome, or cranial nerve palsies, are seen in some patients. These are two of my patients, one who's demonstrating lid drooping, and the other one here who has a difference in the size of her pupils. So kind of subtle, but definitely there. And then whooshing is also common. The pain really tends to precede any kind of stroke symptoms if they're going to happen. And we do see a fair number of people who have isolated pain with no stroke symptoms whatsoever. And I think that really gets back to the circulation in the brain. So we have 4 arteries that go to the brain: the carotids in the front of the neck, the vertebrals in the back of the neck, and up at the level of the brain, it makes a circle. And that's the brain's insurance policy. So if there's any blockage to blood flow in one artery, your brain is still able to get some blood flow through the other arteries. Now, besides CT angiography, which I would argue, and MR angiography are the 2 most common ways we diagnose dissection today, catheter-based angiography, where they actually go into the artery and inject dye, is an option. It's not used as much today. We really only use it when we think we need to treat the artery, which thankfully is quite rare when it comes to dissection. But when a patient has dissection, there's a number of questions that come up. What's the best medical therapy? And when should we do intervention? I'm going to start with those 2 questions before we move through the other 2. And I think the treatment comes back to the mechanism of dissection. So we've got that tube, it's got a tear in the artery, and we've got blood flow on both sides of that tear. And the body's response to that injury is to make a blood clot. Now, in some cases, pieces of that blood clot can break off and travel to whatever is being supplied. So in this case, the brain. In other cases, that blood clot may form and grow and actually block blood flow completely. Now, that traveling blood clot or complete blockage can result in a stroke. If that's going to happen, it's usually within the first week of symptoms. And thereafterwards, thankfully, the stroke rates are very low. They've done some investigation to see which type of mechanism is most likely causing strokes. They did MRIs on patients that had cervical artery dissection, and using ultrasound, these bright white lines are actually detecting blood clots that are traveling up to the brain. And what they found was that 85 out of 100 patients had these traveling blood clots causing stroke. Very few, 12 out of 100, had that blockage in the artery that was causing stroke. And then some had a mixed mechanism. And so that's led to this big debate in cervical artery dissection regarding the use of antiplatelet therapy like aspirin or Plavix versus full dose anticoagulation, like, in some cases, warfarin or rivaroxaban, apixaban. The other names are Xarelto and Eliquis. And which one would be best for patients with cervical artery dissection? Now, I'll tell you, in my opinion, most of the studies to date haven't had enough patients to draw a conclusion. They actually have reviewed the imaging for patients that they were studying for cervical artery dissection, and they found that as many of the people that were included as 20% didn't actually have a dissection. They were using different types of antiplatelet therapy or anticoagulation to draw their conclusions. And so it makes the interpretation of this research really difficult. But I think if you look at all of the evidence together, the bottom line is being on an anticoagulant like rivaroxaban, Xarelto, or Eliquis, apixaban, or warfarin seems to reduce the blood clot risk. But it does come at an increased risk of bleeding because it's a blood thinner. And that risk goes up a lot after 6 months of treatment. And so my approach generally for most patients is to put them on a blood thinner for no longer than 3 to 6 months. If I'm going to do antiplatelet therapy, which may be appropriate for some patients, it's usually going to be aspirin 325. Eventually, after that 3 to 6 month period, I'm switching patients to a low dose aspirin of 81 milligrams a day. And I use the patient's symptoms, how they're feeling in follow-up, and what their imaging looks like on follow-up to make that decision. Some people have silent dissections, meaning we just pick them up when we do that head to pelvis imaging, but they have no symptoms. And so for those patients, I don't do any more than aspirin 81 milligrams a day. Some other general things that are really important: blood pressure control, super important. And we want people to have their blood pressure below 130/80 most of the time. There's really no role for treatment of cholesterol plaque because this is not related to that. So we don't put people on cholesterol lowering medications unless they have another reason for it. Pain is pretty common, although thankfully it gets better with time. And we use the typical migraine therapies with the exception of the triptan medications. Those are something we avoid because they can cause the arteries to spasm. And other therapies like muscle relaxants, et cetera, to help with pain. Thankfully, the majority of patients do really well with medical therapy, and we don't need to do anything more like endovascular or surgical intervention or blood clot busting medication. But if you really have to, because your patients or your symptoms are not getting better, there's no reason really to withhold those treatments in this population. Okay, how can we prognosticate how people are going to recover and what their risk of recurrence is? And when do we need to pursue imaging outside of cervical artery dissection or get genetic testing? Well, what we know about the overlap of cervical artery dissection and FMD comes from a study out of Poland. They looked at 230 patients. These patients were a mix of FMD, cervical artery dissection, and coronary artery dissection, and all the patients got a total body CTA, head to pelvis. And what they found was that about 40% of patients with cervical artery dissection also had FMD. So the rate of overlap is pretty high. And so for that reason, if we're ever seeing a patient who has a dissection and we don't know if they have FMD, we automatically get head to pelvis imaging for them also to look for FMD as a cause of the dissection and for other artery findings like aneurysms. When it comes to estimating the rate of repeat dissections, what we know is that the rate of repeat dissection is highest within the first month. It's about 2%. And thereafter, it's stable at 1% per year. So 1 out of 100 patients who have had a cervical artery dissection will experience a repeat dissection during follow-up. And that doesn't mean it's 10% at 10 years. It's every year, it's about 1 out of 100 patients who experiences that. We looked at our patients with cervical artery FMD at Mount Sinai to get a better understanding of what happens to them over follow-up. We looked at 146 patients over a 15-year period. The breakdown of the patients in terms of women, multifocal FMD, rates of aneurysm dissection was the same as what was being seen in the US registry. So we have no reason to believe that it would be different. All of these patients had more than one carotid artery duplex over the time that they were followed. And the majority were followed for an average of about 3 years. The average number of carotid ultrasounds per patient was about 4. And many had complete head and neck angiography as well. And at 3 years of follow-up, what we found was that 1 patient had a new stroke, and that was actually due to cholesterol plaque, not FMD. 3 patients had a new cervical artery dissection after their diagnosis. And 2 of those patients had had dissections in other areas. So that may just be the way their FMD behaves. But if you look at 2% over 3 years, it's very close to that 1% per year number for regular cervical artery dissection patients. And perhaps most importantly, we didn't find any new findings of FMD that were not present on baseline. So anybody that had beading on their baseline imaging, the beading did not get worse. Anybody who did not have FMD in the carotid or vertebral arteries with string of beads did not develop new string of beads on follow-up imaging. So it doesn't seem to be progressive in that sense from what we can tell. Now, there are other causes of aneurysm and dissection, as I mentioned, genetic causes. You may hear more about this later. Those causes have some very characteristic features that you can pick out on imaging or appearance and physical exam. There are some things we can do on physical exam to try to probe for these findings. And in some cases, we will do that. But generally, if I find a patient with aneurysm or dissection, I do the head to pelvis imaging and I find FMD, I follow them based on general guidelines if they have an aneurysm or dissection. If I don't find FMD, I start looking for other things that might suggest they have a genetic condition that causes aneurysm and dissection, like family history or a big aorta or other aneurysms and dissections. There are rare patients who present with repeat dissections, much more than that 1% or so that we were talking about. And in those cases, I will sometimes send FMD patients for genetic testing to make sure we're not missing something. But it really is a very small percentage of patients because we don't find additional genetic causes of these problems very often in patients with FMD at all. All right, wrapping it up with lifestyle modifications. So the basic story is don't do what this guy's doing, right? We don't want to give extra stress on the arteries if we can avoid it. So what I tell my patient is no chiropractic neck manipulation or cracking your neck for you, no deep massage of the neck area. I would also tell people to avoid headstands or shoulder stands if they're into yoga, for example. Downward dog is fine. Shoulder back massage is fine. For cardio, I really encourage people to warm up and cool down always. And when you're in your intense cardio workout, you want to be able to complete a sentence without totally gasping for air. If you're pushing yourself to that level where you can't finish a sentence, that's too intense. I've moved away from giving people weight limits when they're lifting. Really, the most important thing is you don't want to lift anything that requires you to hold your breath or bear down. That's too high for you. And what we've learned from research is if you push yourself to that level, you can create high blood pressure from inside the body as high as 300, which is super high. I advise people to avoid crazy roller coasters or things that could cause whiplash injury. And then they need to stay away from those triptan medications again, or other medications that can cause spasm of the arteries. We also have some data that there's a class of antibiotics that might increase the risk for aneurysm and dissection. These are the fluoroquinolone antibiotics. They're medications like Cipro, Levaquin that are used for urinary tract infections or traveler's diarrhea. And because FMD can run together with aneurysm and dissection, I advise that patients avoid this medication if they have an infection. And I actually make it an allergy in their medical chart as a way to alert their other providers to try to avoid it. So summarizing all of this information together, basically all patients with FMD need that head to pelvis imaging so we can classify their disease, see where the issues are that we need to be keeping an eye on if present. Now, aneurysm or dissection in the head or the neck is a manifestation of a general artery disease. And so if we don't know about FMD, they also need to be getting head to pelvis imaging. The treatment of cervical artery dissection is really focused on preventing those blood clot complications. And so we're usually discussing blood thinners versus antiplatelet therapy like aspirin for 3 to 6 months, some period of re-imaging, and then titrating down to aspirin 81 milligrams a day. And remember, repeat dissections are not common, even with FMD. The treatment of aneurysm is really dictated by size, location, and patient factors. And again, we're using general guidelines to help us make those decisions. And with that, I thank you very much for your attention.